So welcome, everybody. Thank you so much for joining us for our next community forum. We're really excited about this topic. I know Stephen has been wanting this topic for so long, so we're so excited to have it come to fruition. If you are joining us in person, please just silence your phones, because we are recording this, so folks who can't join, they can watch it at another point in time. We'll start off with just a couple of introductions, some preliminary questions, and then I will open it up to you guys in the room and also those who are watching online. So this is, meant to be a discussion. This is meant to be interactive, so definitely get your juices flowing. Without further ado, I will introduce Stephen, our president and CEO, to say a few words.
Hey, so I'll be quick, just a quick welcome. We're very excited about this. As Margot said, this has been a topic we've been looking to do for some time. We wanted to make sure we got the right group of people to be our panelists and have enough time to prepare for this. So this is like, I think, our fourth one. It's been growing. I think Dr. Anwar has had 100% perfect attendance because he's been to every one, and this is the first one he's a panelist. So very excited to have him and Sarita, who's been a board member, who's been a friend. So always good to see her smiling face, and she brought some good people with her. So that's great as well. And again, a couple of distinguished people in the field of behavioral health, psychedelics, and certification board can't get certified without Jeff. So it's great to have Jeff here as well. So don't be nervous. There, I think last count is 1,000 people that are now online with Zoom. So don't worry about it though, but it should be fine. But again, this is a great topic. Excited for you all to be here. And we're really pleased to be able to do this. Our separate wing is called the Advanced Recovery Institute. So all of our training, all of our education research comes out of that part of our organization. And you guys are now part of that today. So thank you very, very much. We're excited. We'll take it back to Maureen.
All right. And just if anybody does need the restroom, you go out to your left, it's down this side, and should there be a fire emergency, the stairs are to your right. Hopefully we don't need that. All right, to get things started, why don't we just go down the row? You guys introduce yourselves, say what it is that you do, and why it was important for you to be a member of this forum.
So I'm Dr. Ariane Leboeuf. I'm the chief resident of CL Psychiatry, ED Psychiatry over at the University of Connecticut. I'm originally from New Orleans. I think it's important for me to be here just because of the experiences I'm getting through my residency training here with Dr. Rao. It's been really good. I work also with Suboxone patients over at the VA. And so I think that this sort of conversation is something that definitely needs to be had by the community.
Hi, I'm Sarita Rao. I'm an addiction psychiatrist. I'm the residency training director at the University of Connecticut Health Center for Psychiatry. I'm not an expert on psychedelics, but according to Stephen, I am. But I guess being an addiction psychiatrist, of course, I have some knowledge about it. Also, I just wanted to say Dr. Leboeuf was very humble in her introduction. She has a PhD in counseling. She also did 2 years of anesthesia training, then switched over to psychiatry, and she's just been accepted to a prestigious pain medicine fellowship at University of Maryland, where she's the first psychiatry resident who's been joining that fellowship. Wow.
Hi, good evening, everyone. I'm Saud Anwar. I'm a physician by profession, pulmonary critical care doctor, but I'm also currently serving as a state senator representing the 3rd Senate District of towns of East Hartford, South Windsor, Ellington, and East Windsor, and emotionally Manchester. And also, I'm currently serving as the co-chair of Public Health Committee. One of the reasons I'm here is that the first bill that the state of Connecticut passed in 2022 was about a pilot study. And then this bill was championed by Representative Michelle Cook. And in the process of that, I was able to, as a chair of public health, I was acting chair at that time of the Public Health Committee. We had the opportunity to listen to a number of patients from across the country. And perhaps in the course of this conversation, I can talk about the veterans and others, and then maybe even talk about the bill, where we are, and what I have learned so far. So honored to be here. Great to be in this room with where I've learned so much and has allowed me to work on a number of bills because of the conversations I've had in this room. Thank you.
Dr. Anwar has been one of the most amazing supporters of Roots since I got here, and it's just his undying passion for healthcare initiatives as a whole is just amazing. I just told him a little while ago, I'm certainly biased. Just told him a little while ago, please run for governor at some point.
Hi, my name is Peter Grayson. I'm an an addiction clinician by training. I'm also a person in long-term recovery, kind of what brought me into this field and go back to school and all of that. But wasn't long that I got a little disillusioned by clinical practice because of a little bit of some systems challenges, which is what we'll get into. I was very fortunate years ago in practice to be exposed to, then it wasn't called psychedelics, but ketamine in specific, and ketamine-assisted psychotherapy, ketamine-assisted therapy in general. What I saw firsthand, data-wise, was just absolutely astounding, game-changing as far as, trying to reconcile my training, my experience, culturally, what was being said, and now what I was starting to witness and see. Fast forward, the gap that is in existence between what we now know, is out there, data, science, anecdotal, qualitative, quantitative evidence, and what's in practice is so big that we need a lot of change. We need a lot of disruption. So that's really where my focus is now. I have a private practice, director of addiction and recovery at Nushama, a psychedelic wellness clinic in Manhattan, and do a lot of trainings and education to try and bring us down to earth, to temper a lot of the hype and misinformation that's out there. So honored to be here, honored to be among such an esteemed panel. And we need more of this, top-down physicians, part of this conversation. So thank you all. Thank you for having me. Thank you for coming.
I'm Jeff Kwame. I'm the CEO of the Connecticut Certification Board. I come here certainly as a student of psychedelic medicine. I had some interactions with Peter over time, and he kind of taught me a lot and invited me to Nushama. I got to spend an evening there in their environment and see what happens and talk to clinicians and talk to the founders. And I think it opened my eyes. And my main purpose for being here is to very clearly state that our field is an absolute critical mess right now. And we need to move forward with practices that treat patients where they're at and help them meet their needs. And it's time for the field to have seismic change and to accept that things like psychedelic medicine work. If you were here some time ago with Sam Rivera, that's saying that harm reduction works, we need to challenge and change the narrative of our field from fitting people into one box and sliding them in there and saying that this works for everybody. We know in healthcare that doesn't work. And so our goal is to make sure that and to encourage people to have some basic understanding of the evidence around psychedelic assisted treatment, to see that it works. It's something that should be in every clinician's toolbox. And I believe that strongly.
Thank you, everybody.
Jeff's a former employee.
And I'm a former employee. Ray was here when I was here.
Well, thank you so much, everybody. I think where I want to get started with this conversation, as I was researching the topic and getting ready for this, something that I didn't know, and when I was chatting with other people, I found other people didn't know, was that Bill Wilson, the founder of AA, got sober after using psychedelics and then founded AA as a result of all of that. And I think that's really interesting to talk about and to bring up, because the government has it scheduled once. So they say there is no medicinal value to psychedelics. So I don't know, don't fight over it at once, but who wants to take it with, where do you think we go with that piece of information? Since we know, AA, NA, all of those have been so critical and monumental for folks to change in their recovery and provided such support. And we're seeing someone in that realm who's coming out who talks about the benefits of it. Yet on the other side, more bureaucratically, it's taboo. It's no, you can't even look at it, not even for treatment, but for research. And clearly there's a gap there.
I can start and then maybe others can add to it. I think the laws are always behind science. The thoughts come before, then the science comes, and then the laws are lagging behind it. And in this arena, they probably lag behind more than any other places. I can share with you that I don't know how many states have these laws that we at least have one of them that we have passed in 2022, which was a pilot study. And our rationale was to have this pilot study was that there are, FDA has not approved this right now. That's one component, but also there are research that is going on to deal with post-traumatic stress disorder, refractory depression, and also addiction-related issues. So what we did when we proposed this pilot study, the thought was that there are so many veterans and first responders, and we do not have the luxury for the research to come out and the science to come out because we will lose individuals by the time. So what we proposed was that the FDA's, the NIH guided research that is undergoing right now, we wanted to have the same protocols be brought over to the state of Connecticut to one of the medical schools, which most likely is Yale, and to be able to have the same protocols be used, except the money would come from the state of Connecticut. So in the initial 2022, we said based on appropriations that we would have, it was available. And in 2022, we did not have the appropriation money available for it, but we passed the law, we got things ready, we got some of the researchers on board to look at getting ready, and then we have been able to put money forward. So it was supposed to start January 2023, but it's obviously delayed by the lack of enough funds. The course of the public hearing, because this was publicly available even right now, if you go to the CTN and then start to look at psychedelic and do some of the research on it, you will hear a number of veterans. And when we heard them, that was the first time, frankly, I had ever heard of this, and my jaw dropped, because these were individuals who had no hope of recovery and they had tried every single thing. Many of them had tried to hurt themselves. And when they could not find anything, they looked at this option as a last resort. And this clicked, worked, their lives had changed. And obviously the ones who came out to speak were the best case scenarios. So you take that with a grain of salt. It's not a research that I'm speaking of, but these individual stories were so moving that I started to look at this more at that time. And the more I learned, the more intriguing this has been, that we have something that we have not really tried, because we have criminalized this whole thing. We are many, many years behind the potential of some of these medications. And then that's where I'm at it right now with this thought process. So I'll stop here.
I have a lot to add. But yeah, I mean, well, even just picking off on there, right? 22 a day, that's a common statistic. 22 vets are committing suicide a day. My first case with ketamine was with a vet. Treatment-resistant depression, long history of in and out of substance use facilities, detoxes, hopeless case. The idea was, and this is where I appreciate your question, because I'll come back to that and kind of putting it into context. The idea was, wait, now we might have a tool, a power tool like that might be able to do something. Is it a last case resort? Yeah, but compared to what the alternative was, it was pretty compelling. And we were able to engage that individual that afternoon in a very meaningful way. Whereas typically under those circumstances, you're looking at a really long game horizon of when you can even try to engage somebody. So that really showed what we're dealing with in terms of the context, a real power tool. One of the seminal researchers of the field, he's still alive, Stanislav Grof, physician, was one of the original contemporaries of Leary, and then back in the 50s. He has a great quote, psychedelics are to the mind like what the telescope is to astronomy and the microscope is to biology, really illustrating the tool aspect of it. So back to Bill Wilson, right? Back to, what's so much part of the lore to the history is, yes, there was a psychedelic substance, so i.e. a power tool that was administered that might have facilitated a breakthrough that could not have been achieved otherwise. Fast forward about 30 years, he got back into, or not even that long, back into with LSD, tapping into some of those same, contemporary researchers, found tremendous success. And also recognize that in that context, we now have a power tool. Why? Especially in light of the desperation that we're facing of this, what seems like insurmountable issue. If we've got something at our disposal that we can use, why aren't we? At that point, AA had evolved, and the culture that surrounded had evolved into somewhat of what we know today. Bill W. pitched the World Congress at the time, hey, can we look into this? Can we start to do it? It was all shut down. So from that same time of around the seventies, scheduling, the draconian drug laws, everything has been incredibly stigmatized, incredibly shut down. But now where things can come to light, pun intended, and we can really look at what is the data showing? What are the stories that we're hearing, of people who've undergone some of these treatments? And where are the systems currently operating? Where are they broken? And how can we fill those gaps? And it's just such a win-win potential. But I think really the main point I want to focus on is these medications are a tool, a genuine power tool at that, but maybe something that's bringing us from one age to another, the analog to the digital, re-industrialization to now power. So I know that was a little all over the place, but
Bridge that gap when you have the folks on one hand who are seeing this as a Schedule I drug, who are seeing this from the standpoint of when we saw everything get outlawed back in the 70s, when, it kind of hit the club scene and it hit all the music festivals, and suddenly they were not looking at any of the therapeutic benefits, even though there were researchers specifically out in Europe making great progress. I know Switzerland is still doing a ton with it. And I just learned it at Berkeley, UC Berkeley, they have a whole department for psychedelics. I mean, that kind of speaks to, a renowned university like Berkeley, and they have a whole program, directors, everything top down, just focused on psychedelics. How do you think we continue to bridge that gap where you can show lawmakers, you can show people who are at that decision level that this is something that clearly is having a positive effect at some level?
I think to address that, we want to see change at the top, but I think that we need, that change needs to start at the bottom and changing attitudes of individuals who are kind of boots on the ground. And that's not a new challenge for us. We've done that over the years in this field with medication-assisted treatment. We've fought that battle because it's been highly stigmatized, and our individuals that you treat have been discriminated against. We do it with harm reduction, and we're doing it now. This is another battle. So we're skilled at kind of fighting that battle, but we can't just take it head on. We have to work with people who are in the field and say, look what it does, and don't go with your knee-jerk reaction. Because one of my conversations with Peter was, when people think about using psychedelics as treatment, their first thought is whatever their experience was with psychedelics in college, and it's completely different than that, and it's apples to oranges. So I think getting people to see that as a first start is how we start to do that. We cannot influence change at a legislative level unless there's a call for it from the community. So we have to build that community.
Don, just arrived. So Don, if you want to just introduce yourself quickly, tell everyone who you are and why it is that you wanted to join this forum.
Hi, I'm Don. Don Furtman. I'm an alcoholic in long-term recovery, and you can't give alcoholics directions, so that's what happened. I ended up at a different root center, it turns out.
I said it's a problem we have so many.
Yeah, but, for me, I'm a layman on this topic, and for me, it's about finding ways that we can help people find recovery, that we can help people to engage in long-term recovery, and there are different things that work. There are many pathways to recovery. And for somebody like myself, who has, 40 years, it's important that, the people that are sick and suffering find help in whatever format. And I think this is an opportunity to learn some good stuff, especially with the recovery organizations I'm involved in currently. So I'm looking to these astute panel members to feed my lack of knowledge.
Well, thank you. We're glad you're joining us. Ladies, I think I'll direct this next question to you guys, coming from a psychiatry background. Speak a little bit about these drugs and maybe, some people who might be wondering, well, isn't there a potential to abuse this as well? Isn't there a potential to go down the road of addiction with these? What do you say to those folks who have that to say about why it should remain Schedule I, why this shouldn't be something that we're looking into for treatment?
Well, I think one of the reasons we're such a long way off is standardization. As an anesthesiologist, I can tell you a standard dose of ketamine that I need to use. However, with something like psilocybin, golden teacher mushrooms have a different concentration of psilocybin from the root to the cap. So we can't really standardize the dose that we're giving people. So one of our commitments as a physician is to do no harm, right? So there's the standardization of the medication. It needs to be given in a safe manner, and we have to be able to standardize it for everyone that's involved and not just provide like individual supervision. And also what we know about the neurodevelopmental and neurobiology of the brain and the pathway of addiction, we have to be very careful introducing substances with known addiction patterns and activating those pathways in our patients, particularly if they already have a substance use history. So I think that the structure isn't there yet. It's not that we might not get there, because things like ketamine and Spravato have made their way into something that's very, structured and measurable and able to be administered uniformly. And I think that's going to be the most important part for things like psilocybin, LSD, MDMA.
I would say, I'm addiction psychiatrist, and, you really have to look at the neuroscience of the brain and the neuroscience of addiction. So I would agree with Dr. LeBoeuf, and the best treatment for treatment-resistant depression that we have today, and we've had, for a long time, is actually ECT, electroconvulsive therapy, which most patients, if you tell them that, they're just gasp and there goes shock treatments. So, and it is most used actually in the elderly. And the reason it's used in the elderly is because it's so safe. It's safer than, antidepressants, which is really saying something that's safer than Prozac, fluoxetine. But because the only risk is the major risk is the risk of anesthesia, which, if they were going to have some other procedure, they would. So, however, if you take ECT, electroconvulsive therapy, which has 80 to 90% remission rates compared to antidepressants, which we as psychiatrists don't like to say, but the reality is antidepressants have about a 50% remission rate. And a lot of antidepressants, to get approved by the FDA, they don't have to achieve like a full remission in the studies, partial is a certain percentage is good enough. Of course, there are people to whom you prescribe them and they're instantly better. So if you're going to if you're going to really follow the signs of treatment of depression, then you would go down the ECT route, because transcranial magnetic stimulation has nowhere near that level of efficacy. However, people feel better about just using magnets. So sometimes psychiatrists will chat amongst themselves and say, if you were depressed, what would you get treated with? And every single psychiatrist that I've met, except for me, says ECT, right? I'm the only person I've met that doesn't say that. And that's because of a very human, non-physician-like response, because even though I know it's the best treatment, the idea of it like evokes that anxiety in me, right? So I want antidepressants if I'm depressed. But actually, I want fluoxetine and bupropion so I can be happy, thin, and organized. But so I feel like for our, we have to reduce stigma for addictive illness. We have to treat it the same as if it was high blood pressure, if it was, any kind of coronary artery disease, whatever it might be, chronic illnesses, asthma. And so we have to reduce stigma, and we have to really also look at the signs. So when you take anybody with any kind of addictive illness, whatever it might be, even if they're 20 years in recovery, whenever you're introducing another addictive substance into the brain, potentially addictive substance, it just carries the risk of activating addiction, activating some other, addiction. But we use, methadone and buprenorphine, which have been the best treatments for opioid use disorder, with huge, track records starting from the 80s. And is there risks to those? Of course, but, we manage them and we look at everything. Out of all the psychedelics, ketamine is the one that's shown the most benefits. There've been a lot of research in it over the years. There's been research at University of Connecticut. We have Dr. Andy Winokur and Dr. Jayesh Kamath, who are nationally known psychopharmacologists. In fact, we had a study in our inpatient unit a few years ago for ketamine for suicidality, not for something else, right? But most of those studies have excluded people with any kind of substance use disorder or people in recovery. So we really have minimal data. So I would say that if somebody has failed a lot of things, including ECT, then it's definitely something that's worth trying. And at UConn, we have a treatment-resistant depression clinic, and they are going to be starting, ketamine treatment there soon, Dr. Battersby and Dr. Montia Santiago. But there are all these like things on the cutting edge that we still don't know that much about. Recently, there's a functional neurosurgeon who joined UConn, and he was fellowship trained in Canada. He met with some of us, and I didn't know that this was a thing, but apparently there's a lot of research going on with deep brain stimulation and depression, and deep brain stimulation and obsessive compulsive disorder. So it sounds so scary, psychosurgery, but they're not like, because of the history of like, but it doesn't change the person's personality or things like that. So I would say that, as far as the Schedule I goes, I mean, I think that's up to the FDA, and they have to like really research it. And so we're going in a sort of trifurcated direction as a society. On the one hand, we vilify people for using things like cocaine or fentanyl or heroin and try to treat them like criminals or people who had a DUI. On the other hand, there's also like this sort of bigger acceptance of what's considered softer drugs like, marijuana, and then considering their medicinal properties. But all addictive drugs have medicinal properties. I mean, opioids have massive medicinal properties, but you can get in trouble with them too. So you just have to respect the substance, I think.
Can I just add one more thing? So for the Schedule I part, and I think it's worth mentioning, even for the harm reduction world, the biggest hurdle for providing harm reduction in the United States is the federal government. So we have a problem. We cannot provide care because the federal government is 40 years behind in Europe and 20 years behind Canada. And so we've not even caught up to the most clear research answers in the planet to be able to get the federal government to function in the way it's supposed to. And getting schedule change is going to be tricky. So I think we'll have to function in the state to do what we have to do as much as we can. And create more data experience, because the more the states do, the chances of the federal government doing what they're supposed to do many years ago is going to improve.
It's so fascinating that, I mean, I think it's something like 70 something bills are now out in something like 38 states. FDA has approved breakthrough therapy designation over the last 5 years for a number of different psychedelic therapies. So the tides are changing. The AMA has approved CPC codes, but everything that has been said is absolutely correct. On top of the fact that there's still a Wild West kind of landscape out there. There's still a lot of bad actors, a lot of funding, a lot of excitement, a lot of hype. So it's a really dangerous kind of scenario. But as far as the standardization goes, it's worth checking out. It's called the Psychedelic Alpha Bullseye Chart. It's on a bullseye, shows within, all the different phases of clinical trials, within different psychedelic compounds, what's being clinically trialed for what indication. And it's pretty fascinating to see just how many are out there. Really, for the standardization point, all synthesized, so even psilocybin is in its synthetic form. But a lot needs to be done. There's California Treat Initiative, which is kind of mimicking what was done with stem cell research. Ballot initiative right now for $5 billion of funding on a state level. So there's a lot of kind of movement going on. But back to what the federal government will actually do, who knows? But one last point, and Jeffrey touched on this, is the chasm and the gap also between, where's the science, where's even, legislation going, and then culturally and in practice, what's going on. One thing that also I think can be done is a lot of depolarization. there is a potential link, potential, I say, for, abstinence-based recovery and psychedelic therapy to coexist. If ketamine in specific, for example, could be administered in such a controlled setting, why might that have to be looked at so differently than if an individual had to go in for some kind of major operation and be administered a general anesthetic? That might not be a question of, am I now breaking my abstinence under such a setting? It could be very analogized to that. So I think a lot needs to be done, but where does it start here? With these kind of conversations, these kind of experts, and this kind of community forum.
I think it's safe to say that most of the information around this topic is the negative, right? We're more informed. I mean, all the research I did was like blowing my mind because it was all these things. There was so much history to it that I had no idea, because all we see are the headlines and the negative side of it. But Jim Fadiman, they call him the founder of microdosing. So talking about psilocybin, he was interviewed for Wired magazine, and in that interview, it was accounted that 80% of people who had tried microdosing, their sentiment afterwards, and these were all folks who had depression, severe depression, had said, "I'm back," quote unquote. I'm back. They felt like all of a sudden they were themselves again. They found some place that they had lost within them. And you hear these kinds of things, and it just kind of makes you scratch your head a little bit, saying, well, if that could help somebody, why aren't we talking about it? Why aren't we doing it? Perhaps you can shed a little bit of light on some of, since you deal with this firsthand, on some of the other, let's talk about the positive side, the benefits that we're seeing, because I think maybe that's how we also change the conversation, is bringing to light the success stories that there clearly are. Going back to Wilson and AA and starting that whole venture. I mean, how many people has that program gone on to change their lives?
Absolutely. And yeah, I mean, the stories and also the consistency of what's reported and how it's reported is so compelling. But back to a power tool, these medications, these methodologies are tools. They're not the solutions in and of themselves. But one thing I want to bring up, since you mentioned microdosing, I think it's important to note that microdosing is kind of its own topic. The research, the data, and even modalities around it are kind of standalone. One of the kind of inherent value propositions of psychedelic therapy to begin with is it's not as much symptom mitigation as you really are attempting to go to the root causes. Microdosing by nature is more related to symptom mitigation in some regards. I can't claim to be an expert on that, but I do know that the jury's still out as far as the data that's available, the research, the clinical trialing. So I do think it's important to keep microdosing separate, which is tough. It just illustrates the nuances and the complexities, because that's what's talked about the most. That's what we read about the most. That's what, especially with regards to the stories, we hear about the most. Another kind of thing to put into context is addiction and what we're talking about. We're talking about a disease, a disorder, however one wants to define it, that really is only treated after the heart attack happens, after, the stuff hits the fan, whereas the majority of modern medicine is all about early interventions and prevention. So there's another, lack of reconciliation there as well, that what about, the early intervention, the preventative opportunities that we have, before somebody might get to where they're diagnosed as such, and now all, everything's shoved through that one aperture is how we're talking about it, looking at it. So many complexities, but I guess back to your question, the stories, I could go down so many rabbit holes, but they are as dramatic as you could imagine, where that one individual, my first case, Navy SEAL, referred by a very well-known Head Start program out of Weill Cornell, given to us, the facility I was working out of Manhattan, and really hopeless, break glass in case of emergency. The glass was broken. But like I said, we were meaningfully engaging that individual that afternoon. I had lunch with the guy a month ago. He's been thriving for 7-8 years now. Stories like that aren't unique, where it was the breakthrough. The important thing is the therapy, the follow through, the integration, and everything that surrounds it, back to the context of the tool. But I guess I'll leave it at that. Kind of leave it for other people to comment.
You want to jump on that?
I think when we talk about the federal government, we have to understand as well how difficult it is to maneuver anything through there and how conservative they are. Mike Oxley, who was a former congressman from Oklahoma, he's deceased, that once said that the Congress does two things well. One is nothing, and the other thing is overreact. So when something big comes along, we have a history in this country of seeing money get thrown at a problem without a plan on how we're going to spend the money or what's going to occur with it, or even any long-term follow-up. We say, this was a problem, we'll throw this money at it, we'll solve it. You know, there are people that have a belief in their head, say, well, you know what, in 1964, we have a Civil Rights Act, so racism is cured in this country. Or we got the Sacklers, so there's no more opioid crisis. They look at a small part and look at, because we're an all or nothing kind of country in the way we think. And the lawmakers federally, they look the same way. It's you know, they've got their party they got to deal with, they've got their constituents, so they really do nothing or overreact.
So just a point to that, because you mentioned the Sacklers and the whole opioid crisis. You know, when you look at that, I think what we're talking about here is sort of that in reverse, because it took a long time for that to go public. It took a long time for people to understand exactly what these drugs were doing to kids, what they're doing to patients, what it was doing to society as a whole. And, you know, it was kept very quiet, and then it started to come out into the light. And, you know, like you were saying, there's a lot of disinformation out there. There's a lot of negative stories about this particular topic out there. So the negative, it's the reverse. The negative is out in the light, but the benefit is hidden. So we got to do the same type of thing that they did. I mean, it was really a process of, you know, with government agencies grabbing a hold of this and then starting to move it forward. So yeah, on a state by state approach, you know, it's just like legalizing anything, because, you know, legalizing a lot of stuff these days. And if the states get behind it and then people get behind it and you start to actually eliminate the stigma, or at least lessen the stigma, then you have a much better shot at, you know, making this a much more accepted approach.
And I agree. And I think you hit on a point with that the reason that they could get to the Sacklers and things is two things happened. There were stories. People had personal stories, which doesn't necessarily motivate decision makers, but it motivates the community. And they had data, and data motivates the decision makers. So and oftentimes in our field, neither the two can be. We say, oh, our stories matter for individuals in recovery. They do matter to some. Data matters to others. Let's get them together and really approach a larger crowd of decision makers and the community to make this happen.
I think it's worth noting too that, you know, so we're talking a lot about addiction. That's where obviously the Roots Center, formerly Hartford Dispensary, where we got our roots, no pun intended. And, you know, now we are branching out more into the world of mental health. And I think what's really compelling about the world of psychedelics is that, you know, is it addiction that came first before your depression, or did depression lead you to addiction? You know, which came first, the chicken or the egg? But it's for so many different things. I mean, you're seeing depression, folks who are suicidal, OCD, eating disorders. I mean, the list goes on and on. I mean, you have to think that at some point, it's like, at what point are we going to allow the benefit to outweigh what would they say the potential risk is, I guess, you know, and perhaps Dr. Anwar, you can jump in here because you have that perspective at the state level where you see what happens from a government point of view.
I think in the absence of the federal law, but what should happen and can happen is to have centers like Root and others to have collaboration with one of the universities, with faculty, to be able to be part of a research study where we start to answer some of these questions in a much more controlled environment. And then that would give us the data that we are looking for as much. And also perhaps in every research study, there are compassionate use options for individuals. And there may be a way to address the compassionate use when you are in trouble for somebody who needs it, who's not part of the study. I think that's going to be the entry point to look at, because the universities have their structure, but sometimes spaces like Root has far more patients at times. And that's where the community comes in. So I think collaborative effort from some of those may be the way to move forward, and then comes the part about funding. And that's where it gets a little tricky. How do you navigate the funding when NIH has their own structures and funding is already in place? That's where the university resources perhaps could be an option. And maybe the state can help out too, that like we did for some of those components. And it's easy when you're trying to help refractory problems with our veterans and the first responders. They are first in line. But now we have to do it for addiction-related stuff. And then I think ideally, when we had enough ARPA funds, we should have, if we were in place, we should have said, hey, let's allocate these resources into this study right now. But we should start that conversation and say, as soon as everything is ready, as soon as funding comes, we should allocate some resources into this arena for sure.
Should add, it's a kind of an interesting cross-aisle issue right now. I was at what was at the time the largest psychedelic conference over this past summer. It was about 13,000 clinicians from around the world came to Denver. Rick Perry gave the opening speech. Who would have thought? But that was the first thing he said is like, I'm sure you're all shocked to see me, but I'm here because of the veterans. I'm here because of the stories I've heard firsthand. You have Rand Paul and AOC co-sponsoring bills because of those stories, because of the data. So it's really compelling now what is going on. And now kind of having, almost like Don said, the opposite of the perfect storm, or the same scenario where you've got, really compelling figures. You've got cross-aisle collaboration. Harvard was just endowed $15 million, I think, last month, to open a school of psychedelics and consciousness. Hopkins has had one for 30 years. It's out there. It's in existence. It just needs to come more to light, and come together more.
I want to circle back to something you briefly touched on it earlier, and you mentioned, and both of you mentioned, Don, as well, that you're in long-term recovery, and you're obviously very passionate about this topic too. How would you bridge that gap with someone who, say, is in long-term recovery, but maybe struggling, and their apprehension towards using a substance that, again, has been demonized, has been seen under that harsh light that, this is something you absolutely should not be using. It's in that realm of those hard drugs or the drugs to stay away from. But then you're also telling them this could potentially help you and get you to where you want to be. How do you see that difference and maybe, helping someone who's in that position figure out if that's the right move for them in their recovery?
Do you want to take that?
Well, it's what, Bill Wilson dropped acid, right? It's one of those things, there's a folklore behind it, in at least in the AA community, right? And which is a fairly large community, a recovery community. But at the same time, there's still the stigma attached to it because it's like, well, they were looking at that as a possible solution, a possible approach, but they backed away from it. So, maybe we shouldn't go down that road. But at the same time, there are a number of people that, once you take away the substance, once you take away the opioids, once you take away the alcohol, what's left? And there's usually mental health issues. There's a trauma base in there somewhere usually, and there's mental health issues and people struggling in their recovery. And that's where we respond to stories. You mentioned the stories, and that's where the stories come in because people need to hear the stories. They will respond if they hear somebody else just like them who's gone through it. If Peter tells me something, I'll believe him much quicker than I'll believe somebody who isn't in recovery because I know he's been there. And I think it's the same kind of thing with this. People have gone through the treatment and the process. We need to get those stories out to people that are in recovery that can benefit from these types of things. Just like, there are people on antidepressants, there are people on other substances that was a lot of controversy in the AA community about people even taking antidepressants. Like, oh no, you can't be on any kind of substance. That's not true. That's not how it works. We need to integrate whatever we need in order to remain in recovery and live a positive life.
I think the Bill Wilson thing was, and that's why I started this forum with that fact, is that to me, that was a shock as someone who works in this industry. And then to converse with other people in this industry who had no idea. And it's like, why isn't that something that we're bringing to life? Because that's a pretty substantial fact to know that, you know, he went on to find his sobriety and create AA after using psychedelics.
I think it's important though, that we call all the stories. We hear some very interesting stories in the psychiatry office. So while there are a lot of positive anecdotal stories, there are other very negative anecdotal stories. For instance, a microdosing mom unable to get out of her car to pick up her children, but when she did, she was then hit by a car, you know, and she was filming herself on Facebook Live. There are an abundance of stories around the substances. So I think that it's important that we take a look at the entire picture and not always, you know, promote just the positive. Also, we have to take a look at the cultural and health disparities. We know who participates in clinical trials and usually who doesn't. And so a lot of communities, minority communities, and particularly communities of color, are usually horribly underrepresented in clinical trials. So it's something that we have to take a look at whose stories are being told and are they anecdotal, and, you know, looking at the entire picture and healthcare as a whole, particularly if we're going to be community-based and community-focused.
Do you think, and I think, you know, maybe even sharing some of those negative stories as a way to mention of why this is so important that you be guided by a physician, that you be, you know, you're not doing this at home, which I think a lot of people associate these drugs with, you know, maybe they were doing it in college, maybe they were doing it at a festival, versus this is a very different scenario that we're talking about. This is regulated, this is with a prescriber, this is someone monitoring your vitals, and, you know, monitoring you along the way. Do you think that that may be, you know, that may be a missing piece still, that we're not, you know, showcasing that side of things as well, that it's, you know, to differentiate? Because I think when people hear microdosing, when they hear psychedelics, and they may just think of this as something I'm doing at home, but this is a very, very different thing what we're talking about right now.
I mean, having the luxury to be able to participate in a clinical trial also speaks to access and equity. I was speaking with some people before about a patient, and Dr. Rao knows about, that invited me to monitor his vital signs as he took a hero dose of psilocybin. And, you know, dealing with a certain population that has the luxury, the money to be able to engage in these sorts of things, I think you're going to get a very skewed set of data, and you have to be very careful.
How do you think we combat that? What do you think? Where do you think we started that?
I think it's used a lot with decriminalization, destigmatization, being able to recruit effectively, making sure we're recruiting in urban areas and that all groups are represented, and that they're able to participate. How do we get that access and equity? I think that's something we've been working on in terms of like culturally competent healthcare, concordant care, and looking at the disparities in the community itself. I think we're a long way off.
I don't think we have like only negative descriptions in the media. In fact, if you read the popular media, like quite a few years ago, before the pandemic, I read this article in Vogue magazine. I was going to try and find it, but I couldn't really get my hands on it because it's not, you know, I can't just search the Yukon library. And I made copies of it and sent it to all the addiction research scientists at UConn, and also to my addiction psychiatry colleagues. And basically it was, I mean, before the pandemic, so we're talking at least 5 years ago, maybe earlier. And it was this, Vogue magazine often runs a lot of like lifestyle articles and health articles, not just fashion. And so basically political articles. So it just essentially talked about this clinic in Manhattan, which is staffed by really well-trained physicians. Like, you know, if you read where they trained and so on, they have all the pedigrees. And then you didn't even have to go in. You basically met with them virtually, which on some level I think is okay, because now we're seeing so many people virtually. And are we really going to know more about them if they were sitting in front of us? Probably not. And then basically psychedelics were mailed to them, right? But this clinic is not some riffraff like in an alley. It's like only wealthy people can get access to it because it's all cash pay and so on. And a lot of people were getting, you know, benefits from it, but there was no, everyone who was interviewed didn't have any history of substance use disorders, right? They were just unhappy with life or depressed or having some kind of crisis. So I feel like anything that's potentially addictive and is going to be used in medicine is a double-edged sword, right? Now, when you take marijuana, for instance, is marijuana the same as opioids? Of course not. It's not even the same as alcohol. It's like, in some ways, not as dangerous, but does it have its risks? In the emergency rooms, physicians will see young people who are totally psychotic and they've smoked nothing but marijuana. And it's surprising that college-age students will come into treatment for nothing but marijuana, right? I have patients right now that have only come in for treatments for, so that's like not something that's discussed. So I don't think the psychedelic narrative is necessarily all bad because there are so many universities that are doing legitimate research on it. I just think the risk is that, like when ketamine first came out, there were private practice doctors who already started ketamine for cash before the studies were even done. So I think those are the risks. And I think if I had a family member that was in long-term recovery, or I was in long-term recovery, but I'm not a recovering person. If I had a family member that was in long-term recovery and they came to me and said, I want to try like LSD for treatment, I would probably be very cautious, Now, if they were severely depressed and suicidal and everything else had failed, would I see it differently? At that point, of course.
I can just say to you as a clinician's, if you wear a clinician's hat and you have a patient in front of you and your primary goal at that time is to help this individual and you don't have any tools available to you, and then the laws are restricting you, a pure clinician would take all the risks to be able to save that life. And what I have seen, at least in some conversations, is that there are clinicians who are doing this. They're providing this care. They're doing what they have seen in some of the published data, and they are actually helping out. I was just mentioning that I came across somebody who is doing this to some of the people who can afford, but his condition is that for 3 days of the week, he's going to try to help people who cannot afford. So that's how he's trying to find that balance, because there are patients who are dying. And if somebody believes that there's something that's out there and the research is many years behind, what do? I have to deal with some of those things from another perspective. I'm a lung doctor. When somebody cannot breathe and they say, is there anything else? And I say, well, not officially, but unofficially, there is, people have done some experiments and they're looking at some of those things, and maybe we can put you in a study, but we identify ways to help the person out and do what we can. So I think that's happening. Unfortunately, because the studies are behind, the laws are behind, and you are sitting in a room with somebody who needs help. And then I think that's what the clinicians, we just say, well, let me figure out what I can do. And the other thing is, these things are available, relatively speaking, right? So then you have the tools available, and there are data that shows certain dosages can be used. And you say, well, let me find out what I can do. I'm not saying that's the right way to do it, but I'm just saying that's happening. And I respect and empathize with the clinician who has to deal with it.
I think as much as that is true, and that's where my heart is, we have to acknowledge what was said a moment ago. And the fact of the matter is that there are a lot of bad actors out there. There are a lot of, in a very similar way, very consistent bad stories out there. And it's probably going to be those that are going to become the biggest barriers to a lot of the real progress that stands in front of us. So yeah, a lot needs to be reconciled, from, going back to how do we standardize things, how do we protocol better, to how are we even researching and studying these things and breaking down the inequities in clinical trials and access to care. So yeah, we've got to start very granular, but also, from 30,000 feet above. Back to the question you asked also a moment ago, I think it's tied into this as well, which is different forms of stigma. And then back to even, how do you define recovery? How do you, look at good clinicians versus bad clinicians, a lot of clinics that are out there that, are they even medical facilities, or are they, kind of off the radar? Real Wild West, but with destigmatization, education, standardization, we're going to break that down a lot. I'm going to leave it at that, because I was going to go back to the recovery thing, and that's going to bring up a whole nother tangent. So
I just want to jump in on that.
Yeah, I just did a quick Google search since we were talking about this. I just did a search for, addiction treatment psychedelics, just to see what comes up, to see how bad is it. And basically everything that came up was relatively positive. It was, positive articles. Hey, this is what people are looking at. This is what people are working on. And one of the articles starts off 60 years ago, Bill Wilson in AA, and said, maybe he was right. That's how the article started. And it was in Scientific American or something like that. And it just reminds me that, because we know that there are positive results, even though the same treatment doesn't work for every individual. I think we've established that. But this treatment will work for some individuals. And so we need to get it to those people. And, the way to do that is to take this positive stuff and then put it out there, with the appropriate caveats and cautions. You always have that in any study, in any endeavor. And, the more that we can put that positive face on it, the better chance we have at getting people to respond in a positive way. It feels like an obvious statement, but that's what I just saw. It's already moving in that direction. So maybe we've come farther than we thought when we sat down here.
I think the obvious statement, people are blind to it because it's obvious. One thing I want to go back to, something I hold very dearly, and that's informed consent. When we are working with an individual as a clinician, it is our job to put forth the positives and the risks and let that individual make an informed decision. And that means if research changes, if there's some new data, we want to make sure we're telling our folks that. We want to tell them these are potential side effects. This is what could happen, and let that individual make their decision. But I know from being in the substance use disorder field for over 30 years, there's a lot of, well, I like this, so you need to go that way.
Oh, yeah.
Or I found recovery this way, so this is the way
Very much.
you go. And this is not a knock on the fellowships, it's a knock on personalities, not principles.
Exactly.
When we do on our certification application, we have a question that says, John Doe comes in and with an alcohol use disorder and says, I want to stop drinking in any way possible except for AA because I'm an atheist and I believe that it's religious. 9 out of 10 answers are, well, has he gone to a meeting? I'm going to educate him on that it's spiritual, not religious. Nobody says, okay, John Doe, what do you think might work for you? So we have that mindset that, but if I put in there, somebody didn't want methadone, people would say, oh, I'd find 1 million, there's buprenorphine, there's abstinence-based. So we have to get over our own internal bias as a field. And I think we have to admit as a field, we do have an internal bias. And we need to really focus on putting the truth out there, the positive and the negative, and letting the folks that we treat determine what route is best for them based on benefits and risks.
There's an elephant in the room, and there's not a definition of recovery that's agreed upon, especially in the field, especially from the inside. And there's more stigmatization coming from the inside than there is from the outside. And I think if you asked even just some of us, we'd be hard pressed to differentiate between is recovery defined by an ideology and a subscription to that or by the outcome. And those are really significantly different metrics to look at, but that really determines everything. And all too often it's the ideology, which just then can become another form of fundamentalism. So I think it really is difficult to unpack because where do we even start with the definition of recovery? And then like Don said, the appropriate, that's such a key word, who's the appropriate person under what appropriate circumstances? And then what is the appropriate course of treatment? Another thing to add is even with the mail order stuff, I mean, that's going on now also, back to the Wild West. It really is going to the point that there are, very well known, very well established, even publicly traded Canadian exchanges, outfits that you can essentially mail order ketamine to yourself. Really, really potentially problematic, but it's going on. The stories will come out, like you're saying, I'm sure you're already hearing some of them. So how do we reel it all in? How do we kind of bring it back?
I'm just going to add on the positive and the negatives, and to your point, in this situation, theoretically speaking, the negative is not that the person is not going to respond. The negative is you could have a bad trip. And it can be life-threatening to you. So that's something to be aware of as well. So negative is not failure of treatment, it's the condition getting worse. God
And,
forbid.
to that same effect, though, it's worth noting that so many of the drugs or different modalities that are out there now carry that same risk. I mean, we talked about the Sacklers, we can talk about oxycodone right there. There are plenty of people who will talk about the benefit they got from that drug. And then obviously we know there are plenty of people who can't even talk about the mishap of it because they're no longer with us. So there are things that are legal and that are being used that do have a clear as day benefit and a clear as day consequence. But this, it seems that we're discounting it. We look at psychedelics still under a different lens when there are other things that, to me at least, just seem far more scary.
The details are different, but the ongoing battle is the same regardless of what intervention we're talking about. And if Pat Reamer is watching, Pat, I'm gonna say this, we're not talking about stigma, we're talking about discrimination. And it's discrimination against a form of treatment which may be beneficial for some, or which we know is beneficial for some. Not for everybody like every other treatment, but can help folks. And it is this kind of ongoing public discrimination.
I just wanted to say, mental health issues, whether they are substance use disorders or they are, depression, post-traumatic stress disorder, anxiety disorders, psychiatry is a very different field than, every illness has social cultural, underpinnings, of course. Like if you're an unhoused person and they send you out from the hospital and say, eat healthier and you don't even have a place to live, like you're not gonna be able to follow the treatment plan. So for that person, it might be more important to find them a place to live than, their cardiology medications. But if we're talking about, many other parts of the world, like if you look at the rest of the first world, like you look at all of Europe, you look at Canada, and all those societies have universal health insurance. Pretty much everybody, whether they go on, let's say you take opioid use disorder, if they go on an opioid agonist medication like buprenorphine or methadone, they all, if they want to go off to a, residential treatment program, in a lot of places like Australia, New Zealand, the UK, you don't get your methadone treatment from a clinic. You just get it from your GP, which is your primary care doctor, similar to buprenorphine, although even buprenorphine has not really taken off the way it should in terms of availability. And then there's a case manager assigned to you that follows you around and helps you with things. Because obviously your only problem is not how to just stop using, the drugs. You have to get housing, rehabilitate into jobs, maybe repair family relationships, treat your depression, and so on. And then only if you're not doing well, then you get sent to a structured clinic. And then once you're better, you so in Australia or New Zealand, you just go to the pharmacy and you fill your methadone prescription. Now, we don't do that here, right? And if we were to do that without universal health insurance, by universal health insurance, I'm not talking single payer. None of these Western European countries have single payer. And depending on how much money the country has, like if you're talking Scandinavia, Northern Europe, like Netherlands, Germany, there's no waiting list and things like that there. But if you have the same condition in the UK or Canada, you have a waiting list. You could be traveling somewhere else to get your hip replaced. So I feel like it's all those social determinants of health are also important. Like in the UK and in Iceland, I think they have, in terms of harm, a pretty cutting edge harm reduction on one end. They actually have injection sites run by the government now, where you can go and you can basically inject heroin under the oversight of a nurse. They're not saying it's okay to inject heroin. They're just trying to teach you about clean needles. And maybe that's an opportunity to engage you in treatment, give you a sandwich. But they also have universal health insurance. So if that person says, I think I want treatment, they can get a lot of different things. I don't know about Southern Europe, but in Northern Europe, it's impossible to be homeless unless you absolutely insist on it. Like it's not possible. The government will house you, probably in an apartment, not in a shelter. So I don't think you can just, and also some of the some of the rest of the, you take South Korea, Japan. Also, the opioid epidemic is not happening anywhere except the US. We use 80% of the world's prescribed opioids, and the rest of the world uses 20%. So we have to look at everything in a kind of balanced way. We have to look at the positives and the negatives, and both for the individual patient and the larger patient group, we just have to proceed like in a sensible way. And as you were saying, like if a lot of sort of mushrooming programs start that are not regulated at all, then it could actually end up shutting down something that could be beneficial for people. And then people can't tell the difference between, you know, getting esketamine treatment at University of Connecticut and then getting a mail order bag of esketamine from like some random place that's seen you once on Zoom.
All right, we have about 15 minutes left or so, so I want to make sure we leave time to get public questions. So anybody in the room, and then we'll look if anybody's written in on the chat. So if folks can hear me online, leave your questions in the chat and we can direct those over here to our panelists. Anybody in the room? Yes.
So, a lot of very bright people, and you jumped over one thing. I just wanted, is it the criminality is the issue? Is it FDA approval the issue, or is it both? I wasn't clear on that.
I actually don't know the answer to that. And I'm being honest. If criminality is the issue, and how come there are legitimate clinics in New York City mailing you, you know, mushrooms and things? No one's going there to arrest them or shut them down, right? If tomorrow we began to mail like methadone to people, like somebody would visit you from the DEA and shut you down. So, so I don't know what the answer is. The scheduled drug, I mean, I think the cautious nature of the American FDA has its positives and it has its drawbacks. And we have to be honest about that. Like thalidomide was a long time ago, but it didn't happen in the US because our FDA is so cautious, right? You don't have any babies like that here. Was there somebody trying to prevent a mother who was, and actually, you know, I was born and raised in India and my mom threw up all 9 months of her pregnancy and her doctor said absolutely no medications, right? Which some people would consider like crazy, especially since she worked as an engineer for a big chunk of her pregnancy. But I'm grateful, right? Because what would somebody have given her at that point of time? Whereas here she would have never got. On the other hand, there are medications that have been used in Europe for like 13 years before they arrive here because of the cautious nature. Should they be approved sooner? Non-addictive medications even. Yes. So it's like, it's a balance, I would say.
I think perhaps stigma and lack of standardization. And that's part of the picture too.
I think they're really different things. And there's a lot that's going on within this space. Back to that conference, there was like a real chasm between, you know, decrim legalization movements and medicalization movements. Back to that California Treat Initiative, Jeannie Fontana, MD, she's the doc, she's the spearhead behind it all. She was the one, the original stem cell researcher who kind of led that charge, recreating it now. She says it best, like the decrim legalizations, like what we've got in Oregon, Colorado right now. It's kind of like teaching the 9-year-old to drive in the parking lot. They'll do it. They'll get around. They'll probably be okay, you know, but we've got highways, we've got roads, we've got to interact. We've got a lot of complexities, you know. Where do we go once we get out of that parking lot? And the decrim legalization does not do enough to answer where we go. Back to the standardization, back to the protection, safety, equity issues, accessibility issues, so many complexities that the decrim and legalization, I think, only becomes somewhat of a red herring because there's so much more that needs to be done to responsibly, you know, address all of these issues. So really medicalization, I believe, is, but they kind of have to go hand in hand.
Meat says it's all because pharma didn't develop LSD.
Lack of like long-term empirically based evidence. As a physician scientist, it's really important for us to operate from this stance of beneficence, right? To do no harm to our patients and not having the long-term evidence to kind of prove some of these things makes it difficult, I think, at a governmental level. My patients feel really great on cocaine and PCP as well, and they have some incredible stories to tell. But we also know that those sorts of things don't work in the long term. So I think that it's important that we have to kind of take a step back. And while we might be behind the times, sometimes, as Dr. Ralph's story is pointing out about thalidomide, sometimes it's worth it.
Anyone else want to jump on that question before I open it back up? Yes.
Being in the headquarters of an organization that's committed to doing research and studies, what would you recommend? What would you recommend that we do? What we seek to do, I mean, to be part of this, to be part of the process of creating the data science that you need, or, because we're committed to this idea.
I think my answer would be to partner with, research scientists at some of the universities in Connecticut, University of Connecticut, Yale, Quinnipiac, where you have, serious researchers. There's already research going on in all these places and clinical programs also. And that way you have that combination of the community experience and patients combined with the academic scientific expertise.
I was wondering if anybody else had anything. One of the proud things we are in this organization was we were part of the studies, the needle studies when the HIV virus came out. It was places like this that was discovered.
Also, the Root Center did a lot of research back in the day, with hepatitis and the GI, hepatitis C and some of the medications around that. And it participated in a lot of the Root Center participated in a lot of trials for quite a few years that were part of various arms of research studies from the federal government, National Institute of Drug Abuse.
Anyone else have anything to add to that question? Anyone else? Yes.
So I hear a lot of standardization, getting community involvement, and I'm wondering how to incorporate that with indigenous tribes who do use psychedelics, either for spiritual purposes or already use it for mental health purposes, and how we could incorporate them, especially with the Mohegan tribe in Connecticut, being as big as it is, and with the addiction population there also rising, how we could incorporate that community into the conversation.
Well, I think they have so much wisdom, indigenous communities in the United States and all over North America, all over the Americas, right? North America, South America, everywhere, the whole thing. And they have so much wisdom, and they've used psychedelics in a very organized manner, not organized from a Western sensibility, but organized from Native American sensibility. In spiritual ceremonies, religious ceremonies, treatments, but they didn't do it in isolation. It was not in, it was in a very warm, within a community, all of that. So I think there are risks of cultural appropriation, of taking so much, like just taking something and then packaging it and selling it to rich people in Manhattan or anywhere, Connecticut, Gold Coast. But I think so it has to be, I think they should be invited to the table to share their experiences, but I think, and their knowledge, but I think it has to be acknowledged that they're not, we have to respect where they're coming from, which is not a Western medicine perspective. Now, there's some things that have translated over, like acupuncture, for instance, where there's, no culture or very little cultural appropriation. I don't think anybody provides acupuncture and says, okay, this is not from China, right? I've just come up with these needles myself. But yoga, for instance, it's become so fluffy in the US, let's be honest. People are like, wearing their Lululemon outfit, Lululemon, and yoga here is done almost exclusively by women, whereas in India, it's not, a lot of it is done by men. It's considered very difficult to do, but here there are props and, I have to say, I did do Bikram yoga for 2 or 3 years. And it was ironic that my whole life, did not really get into yoga in India, even though my family tried, and American friends and colleagues took me to yoga. So, but in spite of all the controversy that surrounds Bikram himself, who obviously has gone over to the dark side, but the yoga itself was not his. He tried to patent it, but a judge threw it out. But the yoga itself was really amazing. And one of the things I noticed was that there were no props, There were no props, there was no cushions, there was no spraying of any lavender water or anything. You just went, you did the yoga. So I feel like if Native American wisdom is going to be used, then we have to give them a seat at the table. They're already decimated, the populations. They live on reservations. I mean, I'm not criticizing anybody. I mean, like, we wouldn't be here. I'm an immigrant. I wouldn't be here. I'm sort of benefiting from that, from the fact that they're no longer here. So a lot of their wisdom has also been eroded, I think. Plus, they used it pretty responsibly. And we don't know what bad things happened with them. There might have been a person who became psychotic, who they just sort of took care of.
I'm gonna butcher the name, the Shakruta Institute, and they work in collaboration with, in Berkeley, even the federal government in some regards, with some of the clinical trials and reconciling some of the draft language, because how do you, integrate what you're talking about? And look, the irony is with a lot of the compounds and substances, these have been in practice in indigenous cultures for centuries, and we are, working on their shoulders in many ways. So it's a very complex issues, from the proper acknowledgement to the how do you incorporate, and integrate all of the different practices and considerations that need to be brought up. But there is movement. And one of, I think, the exciting things is within this space, how much inherent acknowledgement there is to that from the get-go. Where that goes remains to be seen, but it's a great question and an issue that has to stay at the forefront, because it also impacts accessibility, and equity. So, yeah, thank you for asking.
Right now, there are these like ayahuasca retreats that are very expensive that people can go on and fly on over and get, have an experience. And then the people that are there, they're not compensated equitably, right? They're still in abject poverty when people leave Peru and they leave these other different places and they had their experience. We have to figure out how to do things at a level of fair trade. If we're going to go in there, we have to leave the community better than the way we found it, particularly considering the amount of capitalism and income and that we would gain here in the US. It needs to be fair.
Margaret, can I just jump in for a second? Just on the Native American piece, a question you asked, I don't know if Dr. Bohr is still on the line, but Rich just started the collaboration and the partnership that's about to ensue in January with the Mashantucket tribe, Pequot Health. So, and it's going to be about making sure that their folks are getting the services that they need. And I saw Dr. Bohr was on for a while, maybe he signed off. I would have liked to have seen his opinion and response to this as the CMO of Pequot Health, but that's going to be a big endeavor for us in the coming years. So we're excited about that, because your question is right on.
Wasn't sure if I knew you were probably gonna come in with that, so I'm glad. Anyone else, another question? Yes.
And thank you for providing all the perspective, really helpful for you and that kind of thing. But in terms of what's going on, because I hear Margot say that someone has an experience in their back, that sounds neurological, sounds physical. And Peter, you mentioned this is a microscope for biology, so that sounds like you're opening up a patient for other treatments. Do we know what's going on? How deep is the research for what's going on neurologically when people use these tools?
The short answer is yes. The long answer is people like that could answer it a lot better than me. But yeah, that is where a lot of the science and research has been devoted to, whether it's through functional imaging or just understanding, comparing that with what I know about neurology and psychology. But short answer is yes, and it is emerging in that,
The way psychedelics work is, the basic science researchers have researched this, and it kind of increases neuroplasticity as a sort of all-encompassing description. So the brain is not a static, organ. Everything we think, feel, experience is mediated through electrochemistry. So basically, there are neurotransmitters, they attach to receptors on nerve cells in our brain. The receptors are like lock and keys, only certain chemicals which are made in our own brain, can go in there, or something from the outside that's made in a lab or is bought on the street. And they attach to specific receptors, and then the receptors are sort of like gates, they open and close. There's these proteins called second messengers inside the nerve cell. And then with the opening and closing, basically different kinds of ions go in and out, like positively charged ions like sodium, negatively charged ions like chloride. And then that changes the electrochemical potential of the cell as compared to its surroundings. But at any given millisecond, there's like millions of these things happening in our brain. So let's say I'm having a bad day and, I decide to drink a glass of wine in the evening, obviously not being somebody who has alcohol use disorder. And maybe it calms me down through chemical processes, right? But maybe instead of doing that, maybe I spend 30 minutes talking to Irione, who has a very positive effect on my mood every time I see her, which is every week, getting together. And then I kind of talk to her about, my stressful day, and she kind of talks to me. Maybe I'm even calmer than when I probably am even more calm in a more holistic kind of way than, drinking the glass of wine, which is very chemical, right? So, but both of those processes are changing my brain electrochemistry. Now but neuroplasticity is not for the short run. It's like it's changing it for a little bit of a longer period. And that's the potential for improvement from things like depression and so on. But again, it has to be studied. There has to be some, because the brain is a complicated organ and we don't know everything about it.
There was some research done in 2022. I actually had written this down because it was something that Peter and I had talked about. And the mechanisms, this was funded by the National Institutes of Health, and they kind of identified what the mechanisms of action are when someone is using psychedelic and in the treatment environment. And like you said, Dr. Rao, it induces neuroplasticity. It starts that process going on. But it also, as you said, alters the brain network chemistry. So it's changing the way the chemicals are going back and forth. It changes the way we process rewards and emotions. It can provide or help provide a social connectedness based on what's going on, but it also creates the mystical experience as well, where people are able to often work through some of the trauma of their past. Which kind of leads me to this. If we say we are a trauma-informed field, why are we not studying and using an effective treatment for post-traumatic stress disorder? Why are we rejecting it if we're a trauma-informed field?
I'm going to pick up on that and try and give also a lay metaphor for how some of the mechanisms for action, and please correct me. But kind of related to that, and it's called default mode network, being more and more identified as an area of interest where that could then, and again, as a layperson labeling this, kind of be shut down. And if we then look at it kind of analogous to a computer or piece of technology, over time we accrue bugs, we accrue fire, whatever it might be. So it's not operating the same as it would out of the box. Our networks are isms that form over time, whether through trauma, through other maladaptation, become automatic. Those are defense mechanisms, other, automatic networked responses that under the influence of these substances, it's been shown that that activity shuts down. So those automatic defense mechanisms are inactive. That also provides such a window of opportunity and breakthrough, specifically with trauma and back to being able to engage somebody right away, because that automatic response of shutdown is now, just inactive. So where therapeutically so much of the game is about, just getting through, making that connection. Now you're back to the power tool. You've got that power tool that might have broken through a wall that otherwise it was just too difficult to get through that wall. That's kind of a simple way that I understand it.
Are these effects, do they have a shelf life on the brain? Do they dissipate out, or are they rewiring things for a long time?
The brain is always rewiring. So I think, what does this neuroplasticity mean for the long run? That's what Dr. LeBoeuf was saying, that we don't know yet because there isn't enough long-term research. Like, what happens to that person after 5 years or 10 years or whatever else. So there just needs to be more, research done. And, medicine did fall in love with psychedelics in the past, and did psychedelic involving therapy and things like that. Now we have more like functional neuroimaging and things like that. So the research can really study better what's going on in the brain. Also completely unrelated to psychedelics, ketamine, LSD, any of that. For people in the room who may not know this, in many ways, the future of medicine 100 years later may not lie in any of the stuff that we have now. It might lie in epigenetics and the microbiome. So we have, for every cell we have in our body as human beings, we have 10 times as many microorganisms hanging out everywhere, on our skin, inside our guts. So basically we are 1:10. So we have one cell, we have 10 microorganisms. So we're like a mass of microorganisms that are not a part of us, but that live in us. And they are also being implicated now for like depression and things like that, right? So, and there's studies going on with that as well. So, in fact, I attended this grand rounds for the Jackson Labs a few years ago, where this research scientist said that there's more diversity of flora and fauna in the human gut than there is in Amazonian rainforest with the microorganisms. There's even some preliminary research to show that if the microorganisms in our gut feel like they need more diversity, they'll make us more social. So there's that, and then there's epigenetics. So we used to think that changes in evolution take many centuries, but now we know, for instance, with trauma, like let's say your parents had trauma, then it kind of changes the on-off switches for certain gene sequences. So that's epigenetics. Like for the gene to be active, it has to be turned on and it has to be turned off. And some of those epigenetic changes get passed on right away to the next generation. So all the people we see who might have grown up with a dad who was beaten by his father, it's not just social, like also some of the genetic changes have been passed on in the next generation.
So I just want to add, if I ever do anything wrong, it's the microorganisms. It'll never be.
I think that's a good note to end on. So I want to leave time for you guys to obviously get some more food, mingle with our panelists, ask them questions individually. But let's give a round of applause to our panelists. Thank you to everybody who came here in person and those virtual. These are great conversations that we look to have every couple of months. We're always open to crowdsourcing topics as well. So we're very active on social media. You can write to us through any of the channels or through our website. Let us know if there's something you think we should tackle for the next one. But we always appreciate you guys coming because it's a conversation that certainly needs to be had. So thank you. Enjoy the food. We've got tons of it. Drive safe, and we hope to see you at the next one.